everyone, welcome to StudyMRCOG Part 2 YouTube RRR Series, where we read, revise, and repeat. So today we'll be discussing about the topic of oncology, and I'm Dr. Upasana, and I'm a consultant gynae oncologist and one of the mentors with the StudyMRCOG. Today is a struggle, tomorrow is hope, the future belongs to us who keep trying. Let us see the topics which we need to cover in the oncology module. Ovarian cancer, cervical cancer screening, cervical cancer, endometrial cancer, vulval cancer, staging of cancer, cancer survival, cancer in pregnancy, mainly your cervical cancer and ovarian cancer management in pregnancy, hereditary cancer risk, mainly Lynch syndrome, hereditary breast ovarian cancer syndrome, BRCA1 and BRCA2. So let us see the first question. A 60-year-old woman has come to you with complaints of abdominal pain and is found to have a 6 centimeter ovarian cyst, which is bilocular and has a CA 125 of 40. What is the most appropriate management? So, whenever a 60-year-old or a postmenopausal lady has come to you with an adnexal mass, you need to calculate something which is known as RMI. So what is RMI? RMI is the risk of malignancy index. So here you need to calculate three parameters. One is the menopausal status. So if there is nothing mentioned in the question and they have mentioned 60, that is more than 50 years old, we take it as a postmenopausal woman. Okay. So in case they have mentioned that no, this lady is bleeding, so that is something different. But in case they haven't mentioned, then you need to take a 60-year-old as a menopausal lady. So the menopausal status, the score will be 3. Now coming to the ultrasound features, here she has a bilocular cyst. That is more than one is multilocular. So a bilocular cyst, that is an ultrasound score of 1 and a CA 125 of 40. So the RMI score comes out to be 3 into 1 into 40, that is 120. So now with a RMI score of 120, what should be done? Yes, we all know from the flow chart that laparoscopic BSO is something which must be done if she has an RMI of less than 200. But who should do the laparoscopy? So the answer here is the laparoscopy bilateral self-paying oophorectomy should be done by the lead clinician at the local center. That is answer number, the option number C. So where does this lead clinician come from? So the first algorithm here, which is being followed, is this postmenopausal adnexal mass algorithm. So any menopausal ovarian cyst which is more than equal to 1 centimeter, you need to measure the CA 125. Any cyst which is more than equal to even 1 centimeter. For premenopausal, the cutoff is usually 5 to 7 centimeter, but for postmenopausal, it is 1 centimeter. So here the RMI, they have broadly divided into RMI less than 200 and an RMI of greater than equal to 200. So please remember this criteria. If the cyst is fulfilling all of the following criteria, that is, it is asymptomatic, simple, less than 5 centimeter, unilocular and unilateral, then you can consider conservative management. If any of the criteria is not fulfilled, then you may need to consider her for surgery. Accordingly, if she is on conservative management, you need to repeat the assessment in 4 to 6 months to see, to note down the size of the cyst. If it has resolved, then you can discharge the patient. If it is persistent and unchanged, then again you need to reassess in another 4 to 6 months and then individualize the treatment. If there is any change in features or any of the suspicious features reappear, then you have to consider intervention. If the RMI is more than 200, then you need to do a CT scan of the abdomen and pelvis and refer to a gynae oncology for an MDT review. Always remember MDT is very important whenever you're thinking of oncology. So oncology, urogynae modules, usually you tend to hear this term MDT repeatedly. So if there is a high likelihood of ovarian malignancy, then you should go by with a full staging procedure, which should be done by a trained gynae oncologist. And in case there is low likelihood of ovarian malignancy, then it can be done from with a trained gynecologist, a pelvic clearance omentectomy, and peritoneal cytology. So somewhat a staging procedure. can be done even by a suitably trained gynecologist. So this is another algorithm. So whenever a woman presents to the GP, if she has all the non-specific symptoms like weight loss, fatigue, or more than 12 times a month she has IBS-like symptoms, then you need to measure CA-125. So this is again another SBA which is frequently asked, that if the woman has come to you with persistent abdominal bloating, distension, feeling full or loss of appetite or abdominal pain, then you may need to calculate her CA-125. So please remember, because this is also a commonly asked SBA. Now, coming to the NICE guideline of 2011 of early ovarian cancer detection, here the question has been taken from this particular table. That is, if the RMI score is more than 250, then the operation is performed by a gynecological oncologist in a cancer center, because if the RMI is more than 250, naturally the suspicion of ovarian cancer is very high. If the RMI is moderate, that is 25 to 250, then the operation can be performed by a lead clinician. This is the answer to our question at hand. And if it is low, that is less than 25, then it can be performed by a gynae or a gynecologist also. FIGO staging is always very important for all the cancers. So please go through the FIGO staging. From the FIGO staging, they can ask you an entire EMQ, or they can ask you simple SBS from it, which you should not miss on your exam. So the most important thing which you should remember in this FIGO staging of ovary is 1C1 means surgical spillage if you have ruptured it. If it is an iatrogenic spill, 1C2 is capsule ruptured before surgery or tumor on the ovarian fallopian tube surface. 1C3 is malignant cells in the ascites or the peritoneal washings. Now, 3C is something omental cake. If they use the term omental cake, usually cake, it means a huge, a big tumor size of more than 2 centimeter, then it straight away goes to 3C. Another question which they ask is regarding pleural effusion. If they have mentioned that pleural effusion is negative for cytology, then it will not be 4A. For essentially, for it to be staged at 4A, the pleural effusion, if present, should be positive for cytology for it to stage as 4A. So please go through the FIGO staging once for all the cancers. Germ cell tumors, the most common malignant germ cell tumor is dysgerminoma, and it is bilateral in around 10 to 15% of the cases. The tumor markers associated with the respective germ cell tumors is again a very easy question which is asked. For dysgerminoma, it is LDH. For yolk sac tumor or endodermal sinus tumor, it is alpha fetoprotein. For different sex cord stromal tumors, that is granulosa cell tumor, is an estrogen secreting tumor, so it is inhibin. And for Sertoli cell Leydig cell tumors, these are virilizing tumors, so usually we test the DHEA testosterone. Now coming to the management of germ cell tumors. So whenever germ cell tumors come to us, they are usually adolescent females and usually premenarchal females, or maybe in their early 20s. So in such a case, the most important thing which you need to remember for a dysgerminoma is that you need to do something known as fertility sparing staging surgery. So you have to do the staging, you have to take the biopsy, mental biopsy, and you have to do a fertility sparing surgery. Even if there is bilateral involvement of both the ovaries, you need to leave behind one ovary, so that the patient can conceive later on. Okay, so that to retain her hormonal function. Because these tumors are highly radiosensitive and chemosensitive, if you give her chemotherapy, adjuvant chemotherapy, it will usually melt. These tumors melt like snow. So the chemotherapy regimen which we give for these tumors is usually BEP, that is bleomycin, etoposide, and cisplatin is usually given. 4 cycles are given. Now coming to sex cord stromal tumors, here also they have an age incidence of during the premenarchal and during the perimenopausal age group, that is around the 40s, usually granulosa cell tumor. So here also, if it is in the early group, we usually go for a fertility sparing surgery, because these tumors also do well. They have a good prognosis. However, they are very indolent and they have a tendency to recur back. So in case you think, in case the scan picture shows that this is an advanced case and the patient is not willing for fertility, then you can go for a complete debulking surgery. And here the post-op adjuvant therapy is usually in the form of carboplatin and paclitaxel. Now coming to some of the histological characteristic bodies which are frequently asked. So serous epithelial tumor is associated with psammoma bodies, clear cell tumor with Hobnail cells, Brenner tumor with Walther's cell rest, dysgerminoma with large polygonal cells, lymphocytic infiltration, and fibrous septa. These are the three words which they will mention whenever they are or they want you to diagnose dysgerminoma. Teratoma, yes, we'll see all the endodermal, ectodermal elements, skin, hair, the neural tissue, cartilage, etc. Endodermal sinus tumor has Schiller-Duval bodies. Embryonal carcinoma has embroid bodies. Now coming to borderline ovarian tumor. So borderline ovarian tumor the characteristic thing is it does not invade into the stroma. So here also these females who present to us with BOT, usually they are in their 40s. So in such a case, in case they are in their 40s or 30s and they still desire fertility, you can go for a conservative surgery. So you can, in case there is bilateral involvement, you can do a cystectomy in one side and a unilateral salpingo-oophorectomy on the other side. And in BOT, usually you have to do a staging surgery to rule out if there is an invasive implants. But however, in BOT, there is no role of chemotherapy. This is again very important thing to remember. There is no role of chemotherapy in a case of a BOT. The most characteristic mutation associated with BOT is BRAF or KRAS mutation. Now coming to the second question, that is on endometrial hypoplasia. So a 48-year-old woman comes to you with postmenopausal bleeding. Endometrial thickness is 9 millimeter, that is more than 4 millimeter, and she is postmenopausal. Endometrial sampling is done, and the histopathology showed endometrial hypoplasia without atypia. And she has a BMI of 41, which is important in this case. And the patient was started on Mirena. Will be the surveillance? So here, because her BMI is more than 35, she has a BMI of 41. Here, the answer will be to do an outpatient endometrial sampling at 6 months, 12 months, and then annual. So to answer this question, you have to follow this algorithm. So where we see that in case of an endometrial hypoplasia without atypia, the first management is always to address the risk factors, go for observation. LNG-IUS is again a first line management, that is Mirena in her case. And if she refuses Mirena, then we have to go for oral progesterone. So endometrial biopsy needs to be taken for endometrial hypoplasia without atypia at an interval of 6 months. And for atypical hypoplasia, please remember it is 3 months. So, however, how to follow them up for endometrial hypoplasia? If the BMI is less than 35, then two consecutive negative endometrial biopsies at 6-month interval, then you can safely discharge the patient. But here, the BMI was more than equal to 45. Please remember this equal to sign because they can ask you, they can give you a BMI of 35. Then you shouldn't be confused that where does it fall. So please remember that BMI greater than and equal to 35, you have to treat with two consecutive negative endometrial biopsy at 6-month interval, and then you have to go for an annual endometrial biopsy and review. For atypical hypoplasia, similarly, two consecutive negative endometrial biopsies, but that should be taken at an interval of 3 months, and then 6 to 12 monthly endometrial biopsy and then review. Okay, so all these flow charts are really important because if you know them by heart, you will be able to easily answer the questions. Now coming to the staging of endometrial cancer. As we all know, in FIGO 2023, they have drastically changed the endometrial cancer staging. Yes, they have made it more precise and more complicated to say. Okay, so there has been difficulty in remembering the whole thing. And but still, because we are appearing for the exam, it is very important for us to go through this FIGO staging. So I'll just tell you the salient points regarding the FIGO 2023 staging of endometrial cancer. So now each stage they have divided into three substages. Please note that each stage they have divided into three substages. So see, In case they are asking a question based on endometrial cancer, they will mention you that which staging do they want. If they want the FIGO 2023 staging, if they have not mentioned anything, however, in the options in the EMQ, you see that they have mentioned 2C, 1B, 1C, and they are using certain terminologies which are used in the FIGO 2023, then you have to answer according to the FIGO 2023 staging. So remember, stage one is something which is confined to the uterine corpus and ovary. That is, it is disease is again limited to the uterus. Stage 1A is disease which is limited to the endometrium. Okay, so first remember, first earlier it was less than 50% myometrial invasion, but here it is disease which is limited to the endometrium or it is of non-aggressive histological type with invasion of less than half of the myometrium or no focal lymphovascular space invasion or good prognosis disease. So what is 1A1? 1A1 is if the disease is limited to the endometrial polyp or endometrium. So please remember here 1A1 is only endometrium. 1A2 is less than half of the myometrial or focal LVSI. And 1A3, please remember 1A3 and 3A1. So if you just turn it around, it becomes 3A1. So 1A3 is low-grade endometrioid carcinomas limited to the uterus and ovary. And if you see 3A1, 3A1 is spread to the ovary or fallopian tube. Okay, so it is the opposite. 1A3 is actually synchronous ovarian and uterine primary. However, 3A1 is when the endometrial cancer has actually spread to the ovaries. Okay, so this is the difference. This is two very important stages which you need to remember: 1A3 and 3A1. Now coming to 1B, 1B is more than equal to half of the myometrium. 1C is if there is an aggressive histological type which is limited to the polyp or confined to the endometrium. Now coming to 2A1, 2A1 is cervical stoma, 2B is substantial LVSI. 3A1, as I told you, it is spread to the ovary or the fallopian tube. 3A2 is spread to the uterine serosa. So they have included uterine endometrium, myometrium, less than 50, more than 50, then uterine serosa also in 3A2. Now coming to 3B, 3B is again 3B1 is vagina or parametria, 3B2 is pelvic peritoneum. Please remember this is not abdominal peritoneum, only pelvic peritoneum. 3C again, 3C is metastasis to the pelvic node. So 3C1 is pelvic node. If you add the small I, then it is micrometastasis. 2 small I, it is macrometastasis. 3C2 is paraortic lymph node. Again, small I and 2 small I. Then 4A is bladder mucosa or bowel mucosa. 4B is peritoneal metastasis beyond the pelvis, that is abdominal peritoneal metastasis. So please remember these are very key words which you need to remember. They can ask you pelvic peritoneal metastasis, what is the stage? Abdominal peritoneal metastasis, what is the stage? So you have to be clear about that. Okay. Now coming to 4C. 4C is distant metastasis. So if it has metastasis to the lungs, liver, or the bone, that means it is 4. If available, the FIGO guidelines does advocate doing a routine molecular testing to test for fold mutations, MMRD status, and the P53 abnormality. Because there has been much advances in targeted therapy which can be used in such endometrial cancers. Now coming to how to differentiate and what is the criteria to differentiate between stage 1A3 and stage 3A1. So stage 1A3 and 3A1 can be differentiated and all the following criteria must be fulfilled. All the following criteria must be fulfilled for it to be allotted for stage 1A3. So what are the criteria? Number one is no or superficial, no more than superficial myometrial invasion, that is less than 50% of the myometrial invasion. LVSI should not be substantial. It can either be focal, it cannot be substantial LVSI. There should be no additional metastasis. And if the ovarian tumor should be unilateral, limited to the ovary without capsular invasion or rupture, that is equivalent to PT1A in the ovary. So you have to see that all the features which is suggestive of more distant spread and metastasis, all these features should be ruled out for you to stage it as stage 1A3. That is a synchronous. Now, earlier it was termed as a synchronous endometrioid carcinoma of the ovary and the endometrium. However, now it is renamed it is grouped into stage 1A3. Molecular classification is very important. Just to remember that the good prognosis is with the pole mutation, intermediate prognosis is with mismatch repair deficiency or NSMP type, and P53 abnormal have a poor prognosis. So whenever the question, if it mentions the molecular pathology or what is the mutation associated with the endometrial cancer, then you have to designate it with a subscript. So if it is a POLD mutation, automatically it is a very good prognosis. Automatically the stage becomes 1A, and here you have to write N more POLD mutated. And if it is P53 abnormal, automatically it becomes 2C and P53 abnormal. So this is all about the FIGO 2023 staging. I have briefed it in 2 or 3 slides. In case you guys have any doubt, feel free to ask me in the chat box. And we'll go ahead with the next question regarding the management of endometrial cancer. A 60-year-old underwent TH BSO diagnosed with poorly differentiated endometrial cancer, which is more than 50% myometrial invasion. So what will be the most appropriate management here? The answer is EBRT and brachytherapy. So let us have a look regarding the management of endometrial cancer. So 1A grade 1 and in 1A grade 2, in both these cases, hysterectomy and BSO will suffice. If, however, if you see that the grade is more or the stage is 1B, however, early grade, then you have to do a lymph node dissection and give her vault brachytherapy. If it is an aggressive histology or it is 1A grade 3, that is both the stage is more and the grade is more, then you have to give both EBRT and vaginal brachytherapy. However, remember that since only you can omit lymph node dissection in 1A, grade 1 and grade 2, rest all you have to do a lymphadenectomy. So stage 2, you have to go for hysterectomy, BSO, lymph node dissection, EBRT and VBT as well for stage 1A, B, G3 and for stage 2, the management is same. Stage 3, you have to give sequential chemoradiation. So you have to add this chemotherapy in stage 3. The chemotherapy part is added. And for stage 4, you can go for debulking surgery where you need to remove out all the visible macroscopic tumor, or you can go for a chemotherapy, neoadjuvant chemotherapy followed by surgery, or a palliative RT in case the patient is not suitable for any treatment, or you can go for hormonal therapy in certain cases. Now coming to cervical cancer screening. So these are the two questions we have in hand. A 27-year-old para 2 woman has a routine cervical smear test. HR-HPV is positive, cytology is low grade dyskaryosis. Colposcopy is adequate but normal. So this is really important because the things will change if it is inadequate. So colposcopy is adequate and normal, HR-HPV positive, cytology is low grade dyskaryosis. What will be your next step? Similarly, another question, routine cervical smear, HR-HPV is positive, cytology is low-grade dyskaryosis, however, colposcopy is inadequate. So this thing is very important whether it is adequate or inadequate because accordingly the management will change. So now just let us have a look in the flow chart which will help us answer this question. So the answer to the first question was recall in 3 years. Answer to the second question is repeat colposcopy in 12 months. So this is a very important guideline by the NHS on cervical cancer screening and colposcopy management. It has 3 parts. First is the invitation for screening, sample taking, and HPV testing and cytology triage. Second is colposcopy, including histopathology and abnormal colposcopy management. So the first you need to do always a HPV testing. So primary HPV testing is something advocated by the NHS. So HPV testing, if it is negative, then send out for routine recall. If it is positive, the next step is always cytology. So always remember if HPV is positive, the next step will be cytology. Now coming to the cytology, if the cytology is abnormal, directly you go for a colposcopy. If the cytology is negative, you need to repeat the HPV at 12 months. So this is a very important flowchart. If you just remember these three flowcharts, which I'll be showing you in the subsequent slides, you will be able to answer around 90% of the questions. So HPV at 24 months, if two consecutive HPVs, successive HPVs are positive, even if the cytology is negative, you need to go for a colposcopy. Now coming to the part 2 of the flow diagram. So now this patient has come to the colposcopy examination. You have to see whether the colposcopy is adequate or not. So here from this flow chart, we'll get our answer to the question. So if the colposcopy is adequate, you need to see what was the result which prompted the colposcopy. If it was a high grade HR HPV positive and the cytology was low grade, then the recall is in 36 months, as we saw in the first. This is the answer to the first part of our question. If the high risk HPV is positive and the cytology is high grade or borderline endocervical, then you need to discuss it at an MDT meeting within 2 months. Now, if the colposcopy is inadequate and the HRHPV was positive and the cytology low grade, then you have to repeat the colposcopy in 12 months, as we saw this is the answer to the second question. Now, if the HRHPV is positive and the cytology is high grade or borderline endocervical, then you have to straight away go for a LETS, because this has a high suspicious of it being harboring a pre-invasive lesion. So here, if the colposcopy is inadequate, however, she has a high risk HR-HPV positive and a cytology which is greater than equal to high grade dyskaryosis, you have to do her a treatment in the form of a LEDS procedure. Now coming to the part 3 of the flowchart, that is, if she has an abnormal colposcopy result, what should you do next? If it is CIN1, you need to recall in 12 months, and if it is you will do a recall in 12 months, you will do a high risk HPV testing. High risk HPV testing, if it is negative, then again recall in 36 months. However, if the high risk HPV testing is positive, then you have to again do a cytology. Always remember, high risk HPV positive, the next test will be always cytology. Accordingly, depending on the cytology, you'll go ahead with the first part of the flowchart, that is the part 1 of the flowchart. Now, if it is a CIN2 or a CIN3 or a CGIN, so if it is CIN2 or 3, you need to recall her in 6 months. And if in 6 months you have to see the high risk HPV, if the high risk HPV is negative, then recall in 36 months. However, if the high risk HPV is positive, then you may need to carry out again a cytology testing. Okay. And now coming to the treatment for CGIN. CGIN, you have to provide the treatment and recall in 6 months. High risk HPV positive or negative. If the high risk HPV is negative, then you need to recall in 12 months. And if the high risk HPV is positive, then you have to again do this cytology. So again, depending on the cytology, the whole flow chart will carry on. Okay. So please remember, when you need to call for recall, okay, for CGIN or CIN2, you have to provide treatment and recall in 6 months. However, for CIN1, you did not give her a treatment, you need to recall her in 12 months. So now coming to the next question, which is frequently asked as an SBA. So 46-year-old had total abdominal hysterectomy for a gynae condition, and histopathology was found to be CIN3, which is incompletely excised. She has come after 6 months. So what will be the monitoring done after for this patient? So whenever the patient comes after hysterectomy, how do you follow her up? Depending on the margins, whether it is completely excised or not. So if it is incompletely excised CIN, if it is CIN1, then you need to take this wall sample at 6, 12, and 24 months. If it is CIN2 or 3, then you need to take the wall sample at 6, 12, and annually up to 9 years or 65 years, whichever is later. If 65 years is one which is later, so the answer to this question will be A, that is to do a vault HR-HPV testing today and after 6 months, and then annually till the age of 65 years. So this is in brief regarding the post-hysterectomy follow-up. So in case of subtotal hysterectomy, she needs to remain under the cervical screening program. However, if the CIN is present in the specimen, but you have done a complete excision, Then you need to do a vault HPV testing at 6 months. If it is negative, then you can discharge the patient. If the CIN is present in the specimen, but you have done a complete excision and the vault HPV at 6 months comes out to be positive, then you have to refer here for colposcopy. So this is one area where after high risk HPV testing, you are not going for cytology, you are straight away going for colposcopy. So please remember that. Okay. Now coming to cervical cancer, so the staging of cervical cancer again is important. So A is usually microscopic, 1B is where you can actually operate. 2A is 1B. They have divided into three categories. That is till 2 centimeter, less than 2 centimeter, then less than 4 centimeter, greater than equal to 4 centimeter. 2B is where the parameter is involved, where you cannot go for surgery and you have to go for concurrent chemoradiation. Now, 3C1 is pelvic nodal metastasis, 3C2 is para-aortic nodal metastasis, 4A is spread to adjacent pelvic organs, that is bowel or bladder mucosa, and 4B is spreading to the distant organs. So this is in brief regarding the management. In early stage, that is stage 1A, you can go for simple hysterectomy, radical trachelectomy, or a conization will suffice. In 1A2, you have to go for a modified radical hysterectomy and a bilateral pelvic nodal dissection. 1A1, the risk of nodal metastasis is very less, that is less than 1%. However, from 1A2 onwards, you have to do the lymph nodal evaluation, either it is by sentinel nodal biopsy or by bilateral pelvic nodal dissection. And if she wants to go for a fertility sparing surgery, it will be radical trachelectomy. Usually, we advocate radical trachelectomy for less than 2 centimeter tumors because for more than 2 centimeter tumors, usually the chances of getting an adjuvant increases and you may need an adjuvant therapy, plus the margins are usually positive and the survival rates are not very good. Okay, and usually they tend to come with recurrences. So stage 1B1, you need to do a radical hysterectomy plus bilateral pelvic nodal dissection. Stage 1B2 or 2A1, you need to do radical hysterectomy and a bilateral pelvic nodal dissection. Now, this is a question pertaining to cervical colposcopy and pregnancy. So, you have to remember that colposcopy in pregnancy, the colposcopist has to be a very trained one to identify the subtle differences between the pregnant cervix and the suspicious pre-invasive lesions. So a woman was found to be 20 weeks pregnant when she attended for her colposcopic appointment for high-grade dyskaryosis on cytology. The colposcopic examination was found to be CIN2. So what will be your further management? Here the answer is repeat colposcopy at the end of second trimester. So please remember there are two questions. One is pertaining to colposcopy, what will be your next management, and another is pertaining to cancer, what will be your management. So 32 weeks, stage 1B, one cervical cancer, what will be your next appropriate management? So because she is 32 weeks already, so you need to wait. You may give her an injection of steroids and go for a definitive surgery, go for a classical cesarean section followed by surgery in the form of a radical hysterectomy and a bilateral pelvic nodal dissection. So more than 24 weeks or in the second more than 20 weeks, you can actually go for neoadjuvant chemotherapy and you can wait and for the fetal maturity. But however, less than 20 weeks, usually we need to counsel the patient regarding termination of pregnancy in case she is with an early stage of cervical cancer. Neoadjuvant chemotherapy, if we are giving her neoadjuvant chemotherapy, it needs to be stopped at around 35 weeks, otherwise it causes fetal bone marrow suppression. Now coming to vulval cancer staging again is a very important. So you have to remember 1A is less than equal to 2 centimeter, less than equal to 1 millimeter. 1B is greater than 2 centimeter, greater than 1 millimeter. 2 is if it extends to the lower one third of the urethra, vagina, or anus. 3A if it extends to the upper one third of urethra, vagina, or anus. 3B is regional lymph node metastasis more than 5 millimeter. 3C is node metastasis with extracapsular spread. So please remember, inguinal lymph nodes are the regional lymph nodes of vulval cancer. However, for ovarian cancer or for endometrial cancer or cervical cancer, inguinal cancer are those which are extra-abdominal lymph nodes. So there, if the inguinal cancer nodes are positive, then it is 4B stage. But however, for vulva, they are regional lymph nodes. So please remember this point. 4A is disease which is fixed to the pelvic bone or fixed or ulcerated lymph node metastasis. 4B is distant metastasis. So this staging is usually followed for SCC vulva, and the only exception to this staging is vulvar melanoma, which follows the different AJCC staging status. Usually, it is recommended to document the HPV status, and FIGO staging of vulval cancer is very important because this is actually based on selective collection of prospective data. Now coming to carcinoma vulva management, so you need to remember the tumor-free margins has to be 8 millimeter on histopathological specimen after you have fixed it with formalin, and the surgical specimen tumor-free margin should be 20 millimeter. Deep margin, which we usually take while we do a radical vulvectomy, is the inferior fascia of the urogenital diaphragm. The distal 1 centimeter of the urethra can be removed without causing any substantial urinary incontinence. And while we are doing a lymph node dissection, we are removing both the deep and the superficial inguinal nodes. Lateralized lesion is something which is greater than equal to 2 centimeter from the midline. And management of these lesions in 1A, we will do a radical wide local excision only. No need of lymph nodectomy because the risk of groin metastasis is less than 1%. In 1B, we go for radical wide local excision with lymph node dissection. In a midline lesion, it is bilateral. In a lateral lesion, it is ipsilateral. In case the ipsilateral lymph node comes out to be positive, then you have to do a contralateral lymph node dissection. For 2 to 4A, we go for primary radiation or concurrent chemoradiation, followed by radical surgery with always with a bilateral lymph node dissection. Only for stage 1A, we can omit lymph node dissection. For stage 4B, it is usually systemic therapy and locoregional treatment with a palliative intent. So do let me know in the chat box in case you have any queries or any doubts, and do let us know if you liked the videos or if you need any further videos or any further topics. Do like us and subscribe us. Thank you so much.